when you faint, essentially your blood pressure drops. So that quick event that happens, what you need to do is actually try, and I don't know whether your dentistry beds tilt, but tilting's actually the best. So you want the head down. If the bed's not quick enough getting up, or it's not working or whatever, you actually can just manually lift the legs and hold them up, or get their relative if they've got a relative in with them or somebody that's come in, and then just keep them like that until they come round. When histamine is released into the patient, they get widespread vasodilation and bronchoconstriction. So those two things combined is a bit of a car crash. Even 0.5, because really you're going to get an ambulance within 5 minutes.
It's true.
You're not. So you need to be carrying 2 at all times, and people don't, and particularly if you're teenagers, you've got a handbag that doesn't fit it, it's tricky. I actually think that in a medical centre, Ampules are better.
When you are dealing with a medical emergency in your chair, that stuff can get really scary for dentists. It's not pleasant to have to deal with it, but we need to be sharp. We need to know exactly what to do because our patient's life actually depends on this. This is why it's a legal requirement in the UK and probably around the world to do medical emergencies training every year. And I'm proud that after 6 years of podcasting and creating CPD, we can finally now cover this topic in the true protrusive way and now give you core CPD or CE credits. The GDC recommends 2 hours per year, and in a 5-year cycle, that means 10 hours of medical emergencies training for the dental team, and this is mandatory. Now, most practices arrange some sort of group session where they're doing simulation and hands-on CPR, which is amazing. But sometimes we're left to our own devices and we're watching these little bit slightly boring videos and lectures online, or we're scrambling to buddy up with a neighboring practice to actually get this training done on time. Now, in this episode, I've got a lead nurse and educator in medical emergencies. Her name is Rachel King-Harris. And one of her roles, as well as working in acute medicine, is to teach dental teams everything they need to know about their medical emergencies training every year. So I'm proud to say that after listening to this part 1 and the next episode, you will give a massive tick box for your annual requirement of CPD. But the key thing is that you do it in a true protrusive way. We're going to make it tangible. I'm hoping that Rachel and I, and mostly Rachel, will present things in a way that it actually sticks. Sometimes when the patient is feeling unwell in your chair, we start to get a bit of panic and confusion. Is this just a vasovagal syncope, or could there be something going on with the patient's heart? Is this an anaphylaxis? Should I be giving oxygen? All these questions can come at you at a million miles an hour, and you have palpitations and you're sweating, and medical emergencies are just no fun to deal with. But after today and the next episode, you're going to smash your annual requirement of CPD, and in a way that you're going to retain this information, because every episode we make some premium notes and we just deliver it in a way that's a bit easier to listen to. It's not someone lecturing at you. You're there by osmosis, absorbing these things. And I really told Rachel, I told her I want to create a really compelling piece of content for the dental team, which makes it tangible and relatable and real world. What I mean by that is the topics we cover in this 2-hour training are actually medical emergencies that you're likely to actually see in your practice. And talking about some details that are really important but no one ever talks about. So I'm hoping through that should you be in that unfortunate scenario that you will face a medical emergency because of this training, you will be feeling much more confident, much better prepared, and of course, you won't be panicking in December trying to make sure you've done your medical emergencies mandatory CPD, because we got you covered. Now, to listen to this episode is free for all, okay? The podcast is free for you, but to actually get the certification, you have to answer some questions and do some reflections, and that's possible on the Protrusive Guidance app. You can listen via Spotify through the app, or Apple Podcasts, again, through the app, or watch the video on the app. And the benefit of that is you just scroll down and answer the questions, and our CPD queen Marie will look after you. And once you start doing more CPD with us, we actually send you quarterly certificates and an annual summary of all your certificates, how many hours you've done, and watch this space. There's some cool stuff regarding PDP coming your way as well. The point of saying that is, why don't you get started? Come and join one of our paid plans. I guarantee you'll love it because it's the nicest and geekiest community of dentists in the world, and you get all the CPD, which is not just a tick box. For me, CPD was like easy. I love learning. I have CPD coming out my ears. I probably claim way less hours than I actually do because getting CPD for me was never an issue. But in this busy world, sometimes getting that mandatory training can be difficult. So why don't you head to protrusive.co.uk/ultimate, sign up and make this one the first one that you claim CPD on, and then it'll unlock the over 350 hours of CPD that's currently on Protrusive to date. Now, every PDP episode since its inception, I give you a protrusive dental pearl. This one's going to help you so much, and your practice manager and your principal will absolutely love you. Because a really good thing that we do in the practice I work in is when you open the Medical Emergencies drug kit. There is just the best cheat sheet ever. Like there's these laminated pages joined together, and there's such a great cheat sheet so that when you are kind of in panic mode and you open up this drug kit, it tells you exactly what you need to know in a time of emergency. I'm pretty sure the CQC will also love you when they see you've got this already there. It's a fantastic aid memoir of what symptoms you're looking for, what drug to do, and the management. Should you call the ambulance? Should you not? Should you give oxygen? Should you not? It's all there. So what I've done is I prepared it as a download for you. If you're watching this on the premium part of the app, just scroll down, the zip folder's there. You can download it, laminate it, and put it in your Medical Emergencies drug kit. If you're not on the app, you can still download this for free. To take advantage of these Medical Emergencies cheat sheet, head over to protrusive.co.uk/me. That's M-E, me, Medical Emergencies. Enter your email and I'll email it to you directly. Don't worry, Uncle Jazz always has your back. I promise you the entire team at your practice will absolutely love this. Anyway, let's join now the main episode and I'll catch you in the outro. Rachel King-Harris, welcome to the Protrusive podcast. How are you?
I'm good, thank you. Thank you for having me. I'm excited.
So those of you who don't know Rachel, okay, I'll introduce you. She does our training in the practice about once a year, and I'm always there in the front row. Heckling is the best way. And you know what?
He does it well.
And Rachel's good banter, right? She's good banter. She makes this topic fun. And of all the sort of mandatory training we have to do, like radiation stuff, right? That can get very dry very quick. But this is one training which is, life-saving. This is super important. So what I wanted to achieve with today's show is to make it tangible, okay? Because why is it so often that we forget, right? And we need that annual reminder. And so I'm hoping that the way we're going to cover it today with some of the stories and analogies, it will make, it'll help someone down the road. But also it ticks a box.
It does.
But it ticks it in a painless way so that people can be chopping onions. So you don't know this, Rachel, but the joke that we have, the running joke in the podcast is people are chopping the onions as they listen to the podcast. Two people have told me that they did this early on and I just adopted it. So I always, when I imagine the listeners of Protruserati, I imagine them just chopping onions as they're listening, right?
Hopefully they can chop some more onions while listening to us.
That's right. That's it. We'll continue the onion chopping. And so I want to make just a more fun, upbeat piece of content around this topic rather than someone just watching like a lecture. And so that's the idea. But Rachel, just tell us about yourself.
So obviously my name is Rachel. I have been a nurse now for 15 years. I qualified at the University of Surrey in Guildford, doing my adult nursing, and realised very early on how much I loved emergency medicine. So kind of the hustle and the bustle and the fast-pacedness of it all. So I started my career at the Royal Berks in a sort of acute medical unit, and then realised that actually A&E emergency department was where I wanted to be. So I moved there and have kind of worked there for about 10 years. But I also had this passion for teaching and education. So I did some...
Inspired probably by your parents, right?
Because they're both in education. We talked about this earlier. And then, I did all of my advanced courses. So adult advanced life support, European pediatric life support, and then just kind of built my profile from there, really. And then I met you guys. I think you're one of my first clients, actually, through a colleague of mine, and have been teaching here for probably my third, fourth year now with you guys. So
I think so.
So yeah, my passion is emergency medicine, and I also love education on the side of it. So this is perfect. This is perfect.
Yeah. So I'm so pleased to have you and your expertise, because you know what, I'm like most dentists. I forget. We forget this stuff. And so you are our expert who's going to help us with these things and help to make it more memorable for us and make it more fun and engaging.
And the reason people forget is because if you're not doing something every day, then it goes to the back of our brain, doesn't it? Whereas because I tend to practice this most days, it stays at the forefront. And I think that's why yearly updates are great, because it refreshes you on those things that you kind of park. So yeah, it's great that you're doing this, because actually anyone can listen at any time, even 6 months down the line. Oh, I've forgotten what, she said about X. So it's always recorded, isn't it?
That's true. And I like this. I know a lot of people are watching on YouTube or Protrusive Guidance on the video format, but many people will be listening on a train, on an airplane, and then they can answer the questions later and get their CPD. So core CPD it is, which is great. But what you reminded me here, Rachel, is trauma, dental trauma. I know you're thinking trauma as a medical world, but dental trauma, again, we see it seldom. Like, comes in really rarely, like an avulsion. So someone's actually lost their front tooth, the whole thing, bring it in some milk or saliva medium, and that's such a rare thing. And whatever happens is that, I end up Googling it. So if I know a patient's coming, I'm like, okay, what's the latest guidelines? Okay. Yeah. And I'm not saying that's a wrong thing to do by any stretch.
No.
It's because when I was a teenager, I used to go to the doctors and I noticed that any issue we have, the doctor sometimes just be Googling it. And I used to think to myself, what kind of doctor is this who's Googling it? But actually, why should they be an oracle, all-knowing, all-beast? What they're doing is they're checking the latest guidelines, they're checking information, and then using their medical knowledge to use those guidelines with the patient history and diagnosis to then give a recommendation.
Yeah, and that's like you've just said, guidance publications change all the time. And actually the correct thing to do is always look up the latest guidance, latest publications, because I can say one thing today, but actually even in a year, it could be effectively out of date when particularly the Resus Council update their guidance. So this is why it's so important to refresh, because things change and you can't just...
So it's important to refresh because it's just so important anyway. And so it's like life or death, really. So that's why it's important. Also because we seldom see it and therefore we need that refresher. Okay. And of course, like you said, guidance keeps changing. Like in many things in dentistry and medicine, so we need to stay abreast of it. So 3 good reasons to listen to the end today and answer a question and get your CPD, guys.
And the 4th good reason actually is that it's a good life skill. So despite using it in dentistry, everything we talk about today can be transferable to just being out and about. And the fact that you're, medical professionals, people do expect you to know what to do, even though you might not know at the time. So having those transferable skills into the community with friends, family, even strangers is a 4th really good reason to listen.
Excellent. I love it. The direction we're going to be going in, guys, is I want to tackle the most common medical emergencies first, because it's all good and well learning about the really niche and rare ones, okay, like academic, but then that's what it becomes very academic. I want it to be very tangible. Like, what are you likely to, I always say, something you can apply on Monday morning. Now, hopefully no one will need to apply any of this stuff on Monday morning. But
it's there.
The most likely, 1% chance one would be like a syncope, vasovagal syncope. Perhaps we could start with that. And then eventually, I definitely want to come at anaphylaxis, okay, because I think this is so, especially with the media and stuff and prayer and all these things and how important it is and life or death it is. And then I want to just talk about hyperglycemia and a few others. Then I want to talk about the drug kit, what should be in it. And I think that'll be particularly useful, not just for associates, but to practice principles. I'm sure you've seen where they kind of make that face like, oops, I didn't know, we're not supposed to have that anymore, or I was supposed to order that in, and we can cover that kind of stuff. That sound all right?
Sounds perfect.
All right.
Let's do it.
So in your background in nursing, how often do you actually see a vasovagal syncope, and explain what that is?
So vasovagal syncope is essentially another fancy word for a faint, essentially. And just through the nature of what we do, pretty much blood tests is the biggest one to cause fainting, vasovagal syncope. So we probably see them more frequently than you'd think. It tends to be when you draw up you get the needle out, it's coming towards the patient, they're suddenly looking at the needle and then it pierces the skin. And then what you find is that patients kind of, faint, essentially. So it's actually more common than people think. You don't even need to be needle phobic to not like the look of a needle coming towards you. And I don't know what it's like in dentistry, but from the experience of talking to other dentists that I've taught, a lot of it is just instruments being around their face. And I must admit, there's a lot of people that are afraid of dentists, isn't there? And
100%.
The thought of going in, the thought of sitting there, lying there, and then having them fiddling around with your mouth is enough to make people faint. So I guess it's good to know, actually, we don't really need to panic, but this is what is really helpful when somebody does faint.
But you should, differentiate and diagnose what that is. And thankfully, it's been fairly smooth. So in my experience, Rachel, the most common time I've noticed this is straight after LA. So straight after giving an injection. So I haven't actually had anyone for example, sometimes people are so nervous, they don't want to sit in the chair. So we always sit on the sofa first, that you see there. And then we have calm them down and tell them that we're on your side, we're very gentle here, etc., etc. So everyone's fine that stage. But once they've had a local anesthetic, that's classically what I see. And so what I see them go pale, lose their color. Right.
And that's because all the blood pressure's dropping, isn't it? And so therefore they're losing their fresh face and they're going pale and grey.
My first ever experience of this, I was a 4th year dental student. We were on outreach, so clinics around Yorkshire. And I remember it was a 20-something, or maybe a 19-year-old male. Okay. So I remember maybe reading or coming across something at the time. Is it true that young males are more susceptible to this, or?
We hear that. I mean, to be honest, I have to say it tends to be a lot of female teenagers that I've come across that have tended to kind of have one of these episodes in the emergency department, and they hate needles, and that's their kind of trigger when you come near them with a needle. But I have heard that boys happen to have these kind of reaction when, particularly in the dentistry world. So I'm not surprised you've said it, but I haven't personally. It has tended to be more the female sector. Yeah.
And then quite classically, I used to think that, okay, it's because our anesthetic contained adrenaline. And I used to wonder, is that, because they often describe, oh yeah, my heart's going, and then they start to go a bit pale. And so what we do, and then just to make sure we're doing the right thing, is I was always taught, bring their head back, legs up, let the blood, so the reverse of what's happening. If their blood is drained from their face, if they're looking pale, you want to do the opposite. You want to get the blood back down.
Absolutely. So when you faint, essentially, your blood pressure drops. So that quick event that happens, what you need to do is actually try, and I don't know whether your dentistry beds tilt, but tilting's actually the best. So our medical beds in hospital, we can tilt them like this. So
like left and right?
Up and down. So that their feet literally come straight up and their head down.
It doesn't tilt, but we can actually do it so that the head goes below the legs.
Perfect.
So we can do
That's exactly what we want. So we want the head down. And then if the bed's not quick enough getting up, or it's not working or whatever, you actually can just manually lift the legs and hold them up, or get their relative, if they've got a relative in with them or somebody that's come in, and then just keep them like that until they come round. We used to talk about throwing water over people and, giving them a shake and a tap, but actually it's a very basic thing. It's pull that blood pressure back up to central perfusion and they'll recover a lot quicker.
I remember the first 3 or 4 times this happened to me, I was really scared. I was like, as a young dentist, a student, a young dentist, I was like, oh my God, like everything, angina, heart attack. I was like trying to think, what was the recent guidance? What do I do? But just falling back to that advice of just doing that and remaining calm. Now, I don't want to say that it's blasé. I don't want to be blasé about it. But now if it happens, I'm really calm. I was like, okay, that's fine. Let's bring you back. I'm just speaking out loud in a nice hypnotic tone almost to the patient.
And they're scared because they've come around. But I've got a really funny story, actually. When I say newly qualified, I probably worked in ED for about, 2-3 weeks. And one of my patients needed some GTN spray, so a nitrate. And what a nitrate does is it vasodilates.
So why did they need the GTN spray?
Because they had some pain in their chest, which is separate to the vasovagal symptom.
So they had angina?
They did.
Okay.
Yeah. It was prescribed PRN, which basically means as much as they require as such. So I went along as kind of a new nurse in ED, and I didn't check the blood pressure before I gave the GTN, which in hospital settings is actually really helpful, because if they've already got a lower blood pressure and then you go and give them a drug that vasodilates, the blood pressure drops even more. So he already had a lower blood pressure than normal for him. I went along, gave him 2 sprays.
Because of chest pain, which is the right thing in a way.
And he basically fainted on me straight away. Now, because I was new and fairly inexperienced at the time, I'd only been qualified for about a year or 2, I panicked and I pulled the crash bell. Everyone came rushing in and I stood there and went, I think I've killed the patient. And I burst into tears, and I'll never forget one of the consultants tilting the bed for me, as we just discussed, tilting the bed and saying, no, you haven't. Go and pull yourself together and make yourself a cup of tea. And I kind of walked off sobbing, thinking, oh, he's dead and it's all because of me. But actually what I'd done I should have given him 1 spray, reassessed, checked the blood pressure to make sure he was okay, and then given him a second if he had needed it. But what I did was just go, shh. And then I gave him basically
at that point, the blood pressure scenario and the syncope wasn't your number one worry. It was the fact that he was a patient with angina, so we would automatically associate that with cardiac issues, and therefore I can see
trying to treat.
Yeah, fine. So that makes sense.
It's a lesson. It's 1 spray, reassess, 2nd spray, reassess. Don't just go in gun-ho, because actually sometimes you can make it a bit worse for yourself, even though I know you're treating the angina, but you will cause a vasovagal syncope, basically.
Interesting. Now, later we'll be talking about angina. Yep. So if you just jump that a little bit now, for our angina patients, GTN spray, classically I was taught it runs out of date really quickly, so always check that it's in date.
Correct.
And then I always literally get them to keep it right there, by that telly, I say, keep it there, basically. And I've never need to use it.
Yeah.
But
it's good to have it.
Yeah, exactly. Would you recommend then also doing the same as what you did in terms of what you're recommending, which is one spray and then reassess?
I would always recommend one spray and reassess, even though they may say, oh, I take 2 or 3 sprays for this one, I get it. That's fine if they want to do that at home. But when they're in your surgery, when they're in your practice, you've got a lot of instruments around. The last thing you need is them standing up and collapsing. So I would always do one spray, check how it works, see how they feel. Has it improved their pain? No, it hasn't. Give it a couple of minutes, give them another spray, because you're trying to protect them from injuring themselves, hitting their heads, causing themselves more harm than is necessary.
Okay, so that makes sense. And we'll expand more on that when it comes to the GTN and angina part. Back to vasovagal syncope then. It sounds like fairly straightforward, but the reason I mentioned about the fear as a young dentist is your mind when you're facing a medical emergency is, which one could it be? Is it this one? Is it that one? Is that one? And so what advice would you give to a dentist who something's happening and they're seeing that patient is in some sort of distress, and to just think logically and to give them a sort of a guide to figure out which one it is? Obviously, common things happen commonly, so maybe assume it could be a vasovagal syncope, but by assuming that always, is it that we might be missing something a bit more sinister? And so what advice would you give to a dentist regarding that?
I guess my advice would be is checking, because what you worry about with a vasovagal is that because they have those like moments of unconsciousness, is this actually a cardiac arrest? And what we tend to happen in hospital is that we start shaking the patient and checking their breathing to make sure that we haven't actually caused, or the patient hasn't gone into cardiac arrest. So the advice that we kind of give our colleagues in hospital is you check the breathing, and that's the most simple thing to do. So you lay them flat if they're not already flat.
So let's assume you think it is a vasovagal syncope, but you're a little bit unsure and you're a little bit scared, and so you do the first step anyway, to lay them flat, which works for both. And then next step will be
open up their airway. So head tilt, chin lift. So really pull that head back, making sure that as long as they've not.
So we've got this little headset here that is handy to bring the head back.
And then you look, listen, and feel for breathing. And as long as you can see that chest go up and down, that's breathing. So then you pretty much know then that this is actually a faint. And then the next step that I would do is raise those legs straight away and reassure the patient, talk to the patient. And then they should come around very quickly. Like if it's a sort of, I say a simple, and nothing's ever simple, but if it's a faint, they should come around quite quickly. But it's the differences between knowing if this is a serious unconscious event where we need to start ruling in or ruling out what it could be, is really checking whether they're breathing or not. And once you can confirm that they're breathing, you bought yourself some more time, because then you can start raising the legs to see if that works, and so forth. Obviously, if they didn't come round, you'd start to think about, have they taken anything? Has anyone given them anything? Why have suddenly, is this a blood sugar event? Those kind of things. But initially, if you've done something to the patient or they're nervous or anxious, you can pretty much say this is probably a vasovagal syncope.
Perfect. So the advice here is commonly vasovagal syncope is the most common one that we will face. Bring their head back. But then if you're unsure, just first thing do, check for breathing, and that will reassure you. In my experience, they usually come around 9 seconds to 2 minutes.
Correct.
Feels like 2 hours when it happens, right?
And it does for medical professionals too, by the way. Yeah, you're not the only ones that feel like, are we missing something here? But it's about taking your own deep breath, to be honest, and thinking they're safe, they're on a bed, they're breathing. Almost take a check with yourself and say, they're fine. We just need to work out what this is. Raise the legs. Everything
in our decision making just works way better when our mind is calm, and it's very difficult. I mean, it's easy for me to say,
it's very hard,
it's difficult. But I'm going to give a story which is relevant. It's similar, but it's not medical emergencies. I do a lot of occlusal appliances, splints. It's my area of interest, TMDs and bruxism and that kind of stuff. So occasionally you get one from the lab which is really tight, right? So it goes in the patient's mouth and they are not able to remove it. Okay. And so again, in my early days, I start panicking, thinking, am I not going to be able to remove it?
Yeah.
Now it's like, if they see that panic on my face, that's game over.
Yeah. So true.
Now I'm just really relaxed about it, because whatever it is, I'll get it out. I'm really just calm about that, because compared to a medical emergency, there's nothing, right? Let's face it, right? So if you put things in perspective, it's really no big deal. And I've always been able to get it out. Okay. So it's one of those things that, it really helps me to just not to stay really calm.
Stay calm, work through the process in your head. it's Occam's razor, isn't it? If what it usually is what it is. In other words, we can word that better. But essentially, if it talks like a duck and walks like a duck, it's usually a duck. So if they've just seen a big instrument come towards them and they already don't like you, no offense, Jazz, but you're about to do something like a root canal in their mouth, they're already feeling insecure. They get, some patients are prone to fainting, and some more than others. I mean, I've never fainted in my life, but my husband has a couple of times. If he sees blood, he gets a bit, ooh, whereas I thrive in that kind of situation. It just depends on your personality.
I mean, one thing we haven't mentioned though is as dental professionals, one thing we always do when the patient comes in, even if you're seeing them third time that week, is just check the medical history.
Yeah.
And so that, again, if they don't have any cardiac history, the young patient, no cardiac history, then it will, again, strengthens the cause for vasovagal sympathy. Yeah. Whereas the time where it can get a little hairy, a bit confusing for us, is they already a known angina and they have had a stent placed before and that kind of stuff.
Awaiting a bypass.
Exactly.
Kind of
That's when it gets a little bit hairy. Yeah. But again, check for breathing is a top tip, basically. And
real top tip, because if they're breathing, you've got time.
Yeah.
Yeah. It's when they're not breathing, but then we go down a whole different route.
We will explore that. We will explore that.
Yeah.
Before we move away from vasovagal syncope and then maybe go to anaphylaxis, is there any other point that you want to make on that?
I don't think so. I think the main key points are laying them flat and raising their legs, to be honest. It's actually one of the most simplest things that you can treat. So in a way, my advice would be to don't overthink it.
Good. Stay calm. Don't overthink it. And
check the breathing.
This is the one, check the breathing. And this is the one that we'll be doing for your long career. This is the one that will tally up the most, maybe into 3 figures by the time you come to the end of your career. So
correct.
Right. So, okay, Rachel, now moving on to anaphylaxis.
Yeah.
This is one which I think is more, would you say it's more common than some of the other ones that if you were to rank in order what a dentist may typically see? Or
yeah, I feel like you would end up seeing anaphylaxis more out in the community than you probably would in the dental practice, just because you've probably given yourself quite a lot of protection over the years of removing things that could cause it. Like you're probably a nut-free surgery. You probably don't use latex, am I right?
No, I mean, I don't think anything here is latex.
Yeah, so you probably removed a lot of the things that might trigger.
We talked about earlier, actually. So there was a concern when I was studying at then school that chlorhexidine, some people had severe anaphylaxis of chlorhexidine, and my perio tutor she just freaked out and then she stopped us using it. Whereas I speak to lots of dentists, and actually it has got some good efficacy in reducing something called dry socket. After extraction, you can get a dry socket, and so people use chlorhexidine gel. And a lot of procedures to disinfect the mouth, chlorhexidine mouth rinse. So people got different attitudes. I think it's one that is still quite rare. But at the back of our minds, that's one that's always in my mind now from my experience.
And do you use it in this surgery?
See, because of my bias now, because I've been kind of, she put that fear into me now. I don't use it so much. But yeah, we have it. For example, wisdom teeth. If I'm irrigating wisdom tooth, sometimes I will use that. Yeah. And so that's one I can think of that may be more relevant.
I feel like the big ones are, and particularly the ones you're not necessarily going to know about, are the bees and the wasps. Obviously, there's all the nut family, strawberries, kiwis, they're big ones. But again, these are things that you wouldn't really expect to have in a dental surgery. But because you are an environment medical practice, there's nothing stopping somebody being stung out in Tilehurst.
You have a story about this?
Yes. So one of my other surgeries dental practices that I taught, the exact same scenario. They were nearby the dental practice and they got stung by a wasp or bee, and unfortunately they didn't know which one it was. So they walked into the practice, they went to the reception area and they said, I've come for my checkup, but actually I've just been stung and I'm not feeling great. So obviously the receptionist kind of went into a bit of a, what do we do? So she sat her down in the waiting area, got her, a cup of water, and then within 5 minutes, this lady had started to develop something called a stridor, which is an upper respiratory sound where there's a narrowing of the airway. You get kind of a higher pitched sound going through it. So it's like a noise when they take a breath in. She then developed an expiratory wheeze. So when they took a breath out, they had this kind of widespread wheeze. She noticed some sort of tingling in her lips. And when the dentist arrived, come out of, seeing another patient, at this point, he asked her to sort of stick her tongue out, and it was definitely enlarged. So there was obvious swelling there. She felt terrible. We talk about something called impending doom. I don't know if you've ever heard of it, but it's essentially where the patient feels like they're going to die. And actually, if you left anaphylaxis, unfortunately, that is something that could well happen. So,
and that happens through collapse of the upper airway, right?
collapse of the upper airway, blood pressure dropping, because when histamine is released into the patient, they get widespread vasodilation and bronchoconstriction. So those two things combined is a bit of a car crash, because of course your blood pressure is dropped and your lungs have just gone really tight. So that's why they get that feeling. And obviously their airway is struggling as well. So she was short of breath, she had obvious swelling, she had a stridor, she felt terrible.
Would you have a rash?
Yes, you can develop a rash, but you're not waiting for the rash. And I think that's what, is the key message, is that a lot of people wait for the rash to develop to diagnose anaphylaxis.
Hello, YouTube Protruserati. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode. So I'm so glad you mentioned this, because I remember now in DF1, so that's the first year of dental school, we'd had this simulation in Londec, in London by Waterloo, and I failed that station, by the way. But it was like, they put you in a simulation, and this patient's like, I don't feel so well, I don't feel, and I'm like, oh, is it cardiac, what is it kind of thing, is it respiratory, what is it, right? Yeah. And then the clue was that had I undone the top few buttons, they'd put these red stickers there, and so that's always stuck with me now. Yeah. So Rush, but you don't always get one.
But you should. It's funny you should say that, because when I did my advanced life support course, when the first time I ever did it, they did exactly the same. So the patient was short of breath. I was like waiting for the rash, and then they didn't say it was a rash. So I kind of went down the wrong path. But so don't wait for the rash is my kind of top tip, because actually if you've been stung, you've got upper airway stridor with some swelling, the patient feels terrible, you can pretty much go down the anaphylactic route with this one. So they fortunately recognized it very quickly in the dental surgery, and they got their emergency kit out and they administered the correct dose of adrenaline, IM adrenaline. And
well, let's talk about dosage in a moment, but let's just make it really tangible for dentists, because let's say there is a patient who is allergic. Sorry to use the chlorhexidine. I don't want to make people biased to think that they should be worried about using chlorhexidine so much, but there's the only one I can think of right now. So let's say they're using chlorhexidine gel and they put it in the mouth, okay? And what do you think a patient would start to, what are the clues, initial onset symptoms?
Initially, they start so they don't feel well. That's kind of the classic, like, I'm not feeling very well. Sometimes the rash can develop before the airway, so it could happen that way around.
So maybe perioral rash?
It tends to be more sort of chest, sort of urticarial rash that can develop over time, or it can develop quite quickly. They'll probably say they're not feeling great and that they may have some like pins, like tingling feeling around their lips, and that they feel that their throat's tight. Tight is a real key.
So yes, my cousin who's got a severe peanut allergy, I've been with him twice now, bless him, where, the tightness, like he literally, like he's handling himself almost, like the way he looks like this is not good.
It's so tight, you can't quite, and you're trying to swallow because you're so nervous about the fact that you can't swallow your own saliva, because of course there's a narrowing there.
And you look sweaty.
They look sweaty, they look very flushed in the face. People talk about blue. Blue doesn't happen, like it's flushed.
Okay.
Blue's a very, very, very late sign. And they kind of tell you they feel dreadful. Fortunately, you are lying them down already, so you're already halfway there. But those are the kind of first key signs.
And then voice change?
Voice changes, and then if it's that severe, you will get that stridor. But you are at a very critical point when you hear the stridor, because that's a real emergency airway issue. Because if you're hearing such a narrowing that you've got that noise, it's dangerous and we need to do something.
So that's a little bit later. So hopefully before then we would have acted. So we're looking for just in the impending doom, not feeling well.
Not feeling well. Maybe tingling, shortness of breath. They'll always be short of breath.
Always short of breath, okay.
Anaphylactic, and may or may not develop that urticarial rash quite quickly.
I'm glad you said that, because I was kind of just, from memory, I was waiting for the rash. So I've learned something. Let's not wait for the rash, guys. So we know Articaine, so not Articaine. Articaine is one of the anesthetics that we use that contain adrenaline. So adrenaline is the answer here. And so our emergency drug kit should have adrenaline. Now, is that usually kept in the fridge or?
No, you don't need to keep adrenaline in the fridge. The ampules can be kept in the bag. A lot of practices actually just have an anaphylactic box, and some of them even keep them in each, like in one of the rooms. It's easier because with the bag, right, it's big, it's clunky, you've got to fish through it. The last thing you want to be doing when somebody's got an anaphylactic reaction is trying to wrestle your way through an emergency bag to try and find it.
Well, you're going to love what we have. What I'll do now is I'll just go bring it, and then we can talk through that actually. Okay, so I'm back. I have, for those of you listening, I'm holding the emergency drug kit labeled exactly as so in a lovely green box, but really cool. Next to it was a laminated A4, which I love. It's from the BDA. It's a Warsaw Healthcare Emergency Drugs in the Dental Practice. And it's just got adrenaline, aspirin, the names of the drugs, indication, the dose. It's a lovely little cheat sheet to find. Is it normal for practice to have this?
Yeah, no, not every practice has this.
It's genius. I think that's a simple thing.
Sometimes I give practices which any practice can get essentially, is download the resuscitation guidelines, and they give you anaphylaxis, but they definitely don't give you the rest. So this is perfect.
Yeah, this is good. It's got all the main ones.
As long as it's updated, I think that's the key thing.
Yes. So we'll find out today if it's updated or not.
Because it's very easy, and I really want to make this clear that people can often go to a lot of effort in printing these things out, but actually they don't then update them when new guidance comes out. So if you are going to print and not rely on computers, then please make sure that you're checking them regularly. So, a little admission here, Rachel, I've never actually opened this box in my life. Be a good thing.
It's a good thing.
It's a good thing that you've not used it.
Yeah, but now I'm literally like, I've opened it, and I'm glad I'm doing this exercise, because I'm like, this could happen to me one day.
Yeah.
And just to familiarize myself with it. So guys, as I've opened this, I'm seeing lots of laminated files, and I'm seeing, the first thing I see is an anaphylaxis cheat sheet, just a whole one. So fainting is second. So first is anaphylaxis, fainting is second, then hypoglycemia. And it doesn't say which company this is from or what resource from. So I can only assume it's from research guidelines, maybe. But it's got like a summary. So rapid onset, tells you what drug, management, and it tells you airway, swelling, hoarse voice, breathing, rapid wheezing. It's difficult breathing. The circulation will be pale, clammy to touch, flushing. So it's a really nice cheat sheet. I quite like this.
Yeah.
If you're in doubt. And then it says, okay, management. Okay, so if unconscious, lay flat and raise legs. do not place anything in the mouth. So it's all like really, if I'm imagining being in that really stress scenario, then this is exactly what you need. So what I'll do, guys, I'll make this available to everyone, okay? So in case your practice is not doing this, you can give this to your practice manager, get them to laminate it just like I have it here. And I think I'm really pleased to see this as someone who's imagining myself dealing with a scenario.
Because actually, as we talked about earlier, when our own adrenaline is released, we forget things. And having these kind of crib sheets, go-to sheets are perfect in an emergency. And even in hospital, every crash trolley has the guidance for our nurses and doctors, because we shouldn't be remembering things in emergencies.
So I've already seen this, but like in our imaginary scenario, we've just diagnosed an anaphylaxis. I know I'm looking for. So now I've come across these Ziploc bags, right? These like massive zip wallets. First one in massive writing says seizure, okay? Seizures. And so I'm going to skip past that one. Then I've got one that says heart attack. Then I've got one that says stroke. So already what you said, like, the last thing you want to do is rummaging, but this is quite nice and neat and tidy, right?
Really neat.
I'm looking low blood sugar, skip past that one, severe allergy. I found my zip wallet, so I'm going to put the rest of the box away. So that was, within about 20 seconds, I can find that. I'm going to open it up. Let's see what's inside. This is the flow chart. This is the Reese's flow chart. So this is,
So we need to update this. So you've currently got the March 2008, and actually what you need is the 2021 guidance. So we're
only 13 years out. Come on.
So yeah, we do need to update that. So that's a good thing that we checked.
Okay, but the lovely thing here is, you're great. We know about the Reese's flow chart. We'll get the up-to-date one. But now inside here, there are these pre-made packs, okay? 1, 2, and 3, okay? So this is
They're
one...
needles, are they?
I think so.
Yes, they are, yeah.
Yes, because we use the Compule system. So we'll talk about that in a minute. So there's one label with the expiry date on as well, okay? And there's one for preterm small infants. There's one for all ages and just tells you how much to use. And then large adults, okay? So we got that as well, basically. So that's really handy that I know my patient is an adult, so I'm going to go for this one, for example. And so here's the thing. I had this training from Chris a while ago on how to open the Compule. I don't even know where the Compule is.
Oh, it's there. Ampule, you mean?
Oh, the Ampule. Yeah. It's a Compule because I use composites.
Yeah.
I might.
I assume you don't want me to open that.
Don't open it.
So, yeah. So,
but see, already, right, I in an ideal world, let's be honest, guys, in an ideal world, we'd have the EpiPen or the Jext or whatever, right? So let's talk about that, because when an emergency like that happens, okay, you want something ASAP, right? Like, I know I've been shown how to use it. Right now, if I had to open that, I would literally be sweating and be like,
Do dentists not draw up drugs?
No, okay. Here's the thing: like everything we have nowadays
is pre-filled.
So I know, so Chris, he does Botox and stuff. So I imagine he does that stuff.
Yeah.
I don't. Like the only time I ever would do this is this.
Right. That makes sense.
So let's talk about that, right?
Yeah.
To make it easy for dentists, the best thing is the pens. So I imagine this is cost effective to do it this way.
So I can't, don't quote me on this, but I believe that one ampule is about 8p. Might have gone up recently.
8 pence?
Yeah.
An ampule?
About that.
You think that is that with the adrenaline inside?
Yes. No, that's just the glass. But as I say, don't quote me. That was a long time I got told that. Whereas roughly nowadays, I believe a pre-filled auto-injector is about £40, something like that. So in terms of cost saving, if people are happy drawing up drugs and you're medical professionals, you're going to clearly go for the ampules. The other thing is that you've got 20 doses here, because 1 milligram vials gives you 2 adult doses, because it's 500 mics. So you get 2 doses in 1 vial. 2 doses.
But once you've used one, like once you've opened an ampule,
you can still use it for your second dose. You just pop
the second dose.
Inside.
Okay. But it's like really though, I know you've got 20 doses, but you've got 10 people though. Do you see what I mean?
Yeah. You've got 10 ampules, but you get 2 doses in an ampule.
Fine.
So you've bought yourself a lot of time, because we'll talk about in a minute, I'm sure you'll ask about how often do you give it.
Yes.
But this is clearly way more cost effective than having...
Let's check the expiry on that.
Yeah.
So
you get a lot more on a box of ampules than you do with a auto-injector.
So more time you get expiry.
Yeah. Okay. Whereas with an auto-injector, you get about a year to 18 months.
So this is 2 years.
Yeah.
From here, basically, I can see. So the date of manufacture was December 2023, expiry December 2025.
So you get an extra year, 6 months to a year on expiry.
So in balance, it's not something we see often, right? Anaphylaxis, as we already discussed. But when you have it, in an ideal world, I'm just being a diva associate and be like, hey, why can't we have EpiPen?
Yeah.
But really, if push comes to shove, I'll be able to get some gauze. I'll break the thing.
Yeah.
I'll draw it up. Okay. I might do a sloppy job of it.
Yeah.
Okay.
Do you know what a lot of my other dental practices do is they get those large oranges, and then when their adrenaline expires, they all go around with a needle and they practice injecting it opening the ampule and injecting it into the orange. And they find it really helpful because just even opening a glass ampule, you know, people get nervous because they think it's gonna cut. So my top tip advice for opening an ampule is you need to go on the blue dot of the ampule, and I always get a paper towel, and then I pop the paper towel with the ampule when I crack it, because then if it does split off, it's not going to go in my thumb, because I've been there and done that where I've had a bit of adrenaline in my thumb where I've cracked it. My other top tip is to make sure you get the little fluid out of the top of the ampule. If you just slide it across the workstation, it just takes the fluid out of the top bit.
Explain that one again. So
in every ampule, you'll usually get, where it shakes around, you'll get a bit of a fluid in the actual bit where you're capping it off.
Yes.
So then you've got adrenaline everywhere and you've lost a little bit of your fluid. So by just dragging it across the surface, it just takes I don't know why, but it just takes the fluid out.
Dragging the actual ampule itself before you open it.
Yeah, before you open it.
Okay, now got it.
And then what it happens is it drops the bit of fluid back down into the bottle, so you don't, when you crack it open, you don't get adrenaline on your thumbs.
You don't get a mess and you don't get wastage. Fine. So let's say we've opened the ampule safely. Let's open the box.
Yeah.
Get some tissue paper, break open the ampule using the blue dot side basically.
Correct.
And then I will get the needle. So the needle is the one that's already been labeled. Okay, so you know I like the system. I'm liking this. And then the dose is already written here on a sticker. So my adult over 12 years says 0.5 mil. 0.5 mil
is 500
micrograms
micrograms of the 1 in 1,000.
Yes.
There's two types of strength of adrenaline. You've got the 1 in 10,000, which is what we use, or what is recommended for cardiac arrest, and then you've got the 1 in 1,000, which is used for
so much stronger.
Yeah.
Yep.
So, you know, your practice isn't going to usually buy the wrong thing, and you're not going to have the cardiac arrest, so you don't need to get confused about what's in your bag. But so you're going to take, it's 500 micrograms, which essentially is 0.5 mils, because in each vial you get 1 milligrams.
So I would be drawing up half the liquid basically.
Yeah.
And then I'm going to be giving it to my patient, and from this is me from my memory. Upper, outer thigh?
Yeah, because it's intramuscular. So the thigh is a very good muscle to inject into. If you're doing it correctly, you should go in and then pull back to make sure you're not in a vessel. But a lot of people don't do that, and they just literally inject straight in.
That's what you see in the movies. Like,
yeah.
No one shows a bit where they just check.
No one does a little pullback. And then you instantly reassess your patient. So once you've done something in medical practice, you reassess to make sure that it's worked. So
how quickly? I mean, have you ever had to do this on a patient?
Yeah, loads.
Okay, so tell us how soon
it works very quickly. I mean, within the minute, I'd start to hope to see an improvement within my patient. So
it's amazing, isn't it?
It's an amazing drug. Yeah, it is life-saving, because what it does is it acts in the reverse of what histamine being released does. So we talked about earlier that histamine causes vasodilation and bronchoconstriction. Well, adrenaline causes bronchodilation and vasoconstriction. So you're basically reversing the effects, or hoping to, of the anaphylaxis.
But the fact that you're getting all the symptoms up here and then in the upper outer thigh, and how quickly it travels is remarkable.
It is remarkable. I mean, you're hoping that it's going to show that.
Yeah.
It might not. You know, patients might need back to back. And we talked about the dose, but actually the time between doses is 5 minutes. So every 5 minutes.
I mean, that 5 minutes is like 5 hours.
It will do, especially when your patient is saying, I can't breathe, and they're looking awful. When, you know, in hospital, we've got them attached to monitoring and we can actually see how awful they are. Whereas in a way, being blind is sometimes helpful, because you can't see the fact that their blood pressure's dropped. You can't see the fact that they're tachycardic. So you're kind of waiting, set your stopwatch, because you shouldn't have to try and find a clock and be like, oh, just remember what time we gave it. So set your stopwatch for 5 minutes. And then when the 5 minutes goes off, you give another dose if there's...
Should you need to, right?
Should you need to. If there's little to no improvement.
Yeah. So in your experience, how many patients have you jammed who are getting real anaphylaxis?
Gosh, in my whole career?
Yeah.
Not as many as you'd probably think, but maybe like 50.
Okay. So of them, how many needed the second dose?
40.
Oh, so it's okay. So assume we will need it then.
Yeah.
Okay.
Absolutely.
See, that's useful. No one talks about that.
Yeah.
Right? Even you should have told us that last time you were here.
Sorry. I'll put it in my script for next time. But no, you're not, particularly if they're as severe as we've described this, you know, we're describing a very severe case of anaphylaxis, and actually one shot is not going to necessarily get them better. It'll help, but you may need to give a second dose, a third dose. And just remember that the GPs only actually prescribe patients with 2 auto-injectors. So they've only got 10 minutes and then they need an ambulance with them to potentially give them the next dose. Obviously, you're hoping that it will make a big improvement and it will buy time. But there have been some, big cases that we've heard about in the news where patients have even had other people's EpiPens that they kind of volunteered their EpiPen forward, or auto-injector, should I say. And even then they've not been enough. So, I always think having ampules is better because we talked about the fact you've got 20 doses in there. Whereas if you just had one EpiPen, that's 1 dose.
I didn't think about it that way.
Yeah.
You've actually changed my perception of it, because I was thinking, this is a cheap way of doing it and it's annoying for me, but you're right. And if a practice has an auto-injector, to use the correct word, would they only have 1?
So usually they'd only purchase 1 because they're so expensive.
And therefore is good for 2 shots, right?
And no. So there's 3 sort of main ones on the market that I know of. You've got EpiPen, Jext, and Emerade.
So EpiPen's like the Hollywood one. Everyone's heard of it.
Because everyone calls all of them EpiPen, where it's actually they're an auto-injector.
Epinephrine.
Yeah. So you've got EpiPen, Jext, and Emerade. Now, EpiPen and Jext are a 300 microgram dose. Now, if you look up your chart...
How would you do that?
Exactly. We've tried looking this up over years and years about why they are erring on the side of caution by only putting 300 which is actually a child's between 6 and 12 dose. But we don't know why they've done it. Whereas Emerade do a full 500 microgram dose. But the trouble is with these auto-injectors is that there's shortages of one every single time. So if I say, Emerade will be the best one to get, you can guarantee there'll be a shortage of it. So it's kind of whatever you can get hold of. But when you think about it, most people get given 2, but they're only getting 2 300 microdoses. And also they usually only ever carry 1 because they leave the other one somewhere else.
So really got 3 minutes or 4, if it works.
You really need to carry 2. That's my advice for everybody that's listening.
That's using those brands that have 0.3.
Well, even 0.5, because really you're going to get an ambulance within 5 minutes.
It's true.
You're not. So you need to be carrying 2 at all times. And people don't. And particularly if you're teenagers, you've got a handbag that doesn't fit it. It's tricky. And you need to make... So I actually think that in a medical centre, ampules are better.
There we are. So,
cost saving, plus you've got more doses.
I'll have to apologise to Chris. I'll eat my hat. Okay, fine. So that's useful. Now, we haven't talked about this, right? So let's say I've jabbed my patient. They're starting to feel a bit better, but how much better do I want them to be before I decide at 5 minutes to give them the next dose? And also, we haven't talked about, do I need to give them oxygen? And at what point do we call the ambulance?
So oxygen is a must because, of course, they're short of breath. They're going to...
So EpiPen first or oxygen first?
I would go EpiPen first.
Yep.
If I didn't have multiple people doing multiple things. Obviously, in an ideal world, you'd have you and Chris and your dental nurse and you'd all...
Yeah, it'd be teamwork. We do a big shout out, everyone calm.
So one of you would be putting oxygen on, one of you would be giving the auto-injector or the ampules, and the other one would be raising the legs because, of course, what's happened with histamine being released? Vasodilation. So what you want is to pull that perfusion back, raise the legs. So oxygen is really important if you've got it and you are in your dental practice. So there's 3 parts to a cylinder usually. You've got the little grey cap that you need to flip down. You've got the little...
Should I bring it?
Yeah, sounds good.
So we'll still make it descriptive for those listening, but anyone who's watching will make it visual. Okay, I walked in the room with this big green bag. It doesn't actually say oxygen on it. It says Lifeline Emergency Resusc Equipment. Right? I actually wanted to say O2, oxygen on it. Yeah. So this is the first time I've ever had to get the oxygen. I've never had to give the oxygen either. So for me, I'm learning a lot here in terms of the actual experiential, real-world simulation of what could happen in this practice. So there we are. So the green bag, I imagine at the top, there we are. See, I don't know where the zip was, guys. So this is definitely new for me.
And then the other one.
And the other one, look at that. So Rachel's been very, very helpful in terms of,
It's a nice bag.
It's not your first rodeo.
No. And
okay, it's a strap.
Yeah.
And are they all like this?
In hospital, we just have them on the side of our trolleys. But yes, in the dental world and the GP world, they usually are. Yeah.
And so as soon as I open it, again, laminated cards, and it's a resus, and this one is August 2023.
So someone's obviously put their own little, but they're fine. Yeah. Perfect.
And this is for pediatrics?
Because it's the 2021 guidelines, which is exactly what you want.
Okay, perfect. So anyway, I've just diagnosed someone with anaphylaxis. I want to go straight for the kill. And we get this tank here.
So you want to pull the oxygen out of its little holder.
Okay, so there we are. It's got a nice little, so it's got a grip on it, guys. It's got a grip. Now, yes, this is what I want. Something that clearly says oxygen on it.
Yes.
Perfect. Okay.
So
don't actually do it because I don't want to get tagged by Chris.
No, I understand. So what you've got at the front is obviously how much is in there. So you can see it's in the green, so you pretty much got a full tank. If it's in the red, you need to replace that.
Okay.
And then you've got the grey part that I was talking about, which is essentially the bit you're going to flip down.
Oh, that's easy.
Yeah, really easy. And then that means now you've got your port to put the mask connector to. And then the other black part that I was talking about is this part here where it says open. Now, they should be always set on close because obviously you don't want any worries about leaking oxygen. So what you would do is turn it the way it says open, which don't worry, this isn't going to do anything. So you turn it really easy. And then now you can just turn up your dial like so, all the way to 15, which is the maximum that you can go. And you would give your patient 15 litres of oxygen.
So in dentistry, am I right in saying it's easy because the answer is always 15?
To be honest, with a non-rebreathe mask, which is the one you're going to have in your bag, the answer is always 12 to 15, but I would just go 15 because why? Like, let's not confuse matters because that's the highest amount you can go. If they're having a severe anaphylaxis, you'd want to give 15 litres anyway, but you can drop down to 12. I don't want to overcomplicate things, but in hospital, we might err on the side of caution if we had patients with long-term respiratory conditions and we wouldn't want to flood them with oxygen. But in the community, you're not thinking like that. You're thinking, I need to treat what's in front of me, so I'm going to give them 15 litres.
Okay, so 12, 15, I think I always remember 15, so that's easy to do.
Yeah.
I mean, I was on the receiving end of oxygen recently, actually. Last month, I had a pneumothorax. A spontaneous pneumothorax. My lung collapsed, and so I was there in hospital just like on oxygen. And actually, 15 litres for someone who wasn't, yes, it was kind of acute, I guess, but I felt the flow. It was a decent flow.
Spontaneous pneumothorax is pretty acute.
It was pretty acute, but even then I was like, whoa, this is a nice rush of oxygen.
Yeah.
So
was it on the reservoir bag?
It was in a nasal tube in my nose.
Yeah. You probably wouldn't have as high as that, but...
Okay, admission, guys. Here's me being very honest. I think they said it to me as 10 or 8, but then I was like, hey, I'm a dentist. I remember 15, so I turned it up myself to 15.
I love your honest shape.
So maybe it makes sense now.
Maybe that's why it was so high.
Okay, so I found the oxygen, and I know what it looks like now. I know what the bag looks like. I know how to open the zip and the Velcro now.
And the top tip for giving your patient via your non-rebreathe, because they're called a non-rebreathe mask, is that you must make sure that you fill up the reservoir bag. So you might see a lot of like medical programs like Holby City and Casualty where they leave a flat bag on a patient's chest, and actually then you're not getting the proper oxygenation through the reservoir bag. So put your finger over the valve, make sure it fills up with the oxygen before you pop it on their face.
Okay.
Because that's a really key thing with non-rebreathe masks.
I think next time you're here, I think these kind of things that we'd like to see and do.
Put it on. Yeah,
exactly. So that makes it very useful. So while we're on the topic of oxygen, what are the different conditions? So stepping slightly away from anaphylaxis, we'll come back to anaphylaxis, but what are all the different medical emergencies that we may see as a dentist that require oxygen?
So probably the most common one would be asthma.
Yep.
So patients could come in, you can get patients who manage their asthma really well, or you can get patients that, even just a bit of pollen can trigger off their asthma, or the fact that they walked here or something or ran here. And patients might come in feeling a bit wheezy, short of breath. They might tell you that they're asthmatic. You'd hopefully know with an adult whether they're asthmatic or not. They should know. And severe asthmatics would need, a sort of, we call it an asthma attack. But if somebody is suffering with that asthma, they might need oxygen because actually their oxygen saturations will drop. So that's one of them.
Which actually reminded me, should we be, because there's a lot of people, a lot of practices have got those oxygen
I'm sure you did have one, but I could be wrong. But yeah, oxygen.
I feel like they're so cheap.
They are cheap. COVID made them a lot more accessible, didn't they? So yeah, I think they're really helpful. Obviously, if your patient is peripherally shut down, i.e. the peripheries are cold or, there's not enough blood going to them, then it's not going to give you an accurate figure. So you just need to be mindful that obviously it's not the be all and end all, but they give you a good indicator and it should be above 94%.
Yeah, but if they've got anaphylaxis, we know the guidelines say oxygen. So
correct.
Asthma,
just give it anyway.
Oxygen.
Asthma, if they're sort of severe life-threatening asthma, you need to give them oxygen. obviously cardiac arrest, but that's again a bit of a given. We could continue down the lines of all the respiratory, but I don't know how far you want to go, but patients with COPD that are really struggling, so chronic obstructive pulmonary disorder, if they're really severe, they may need oxygen, but we're also very cautious with those because they can't have too much oxygen because they retain it, or retain the carbon dioxide.
Are there any medical emergencies that we see as dentists that actually oxygen is contraindicated? Because you know what, I'll be honest with you, because I'm thinking like when push comes to shove and I'm like trying to remember everything, I'm like, oxygen probably sounds like a good idea. You know, a lot of people might just say, just get the oxygen anyway, kind of thing. Could we be doing more harm?
The only thing really is with chronic obstructive pulmonary...
very niche.
Yeah, very niche. And actually, the rule is that you always treat hypoxia first before hypercapnia. So you must treat their oxygen levels before anything else. So I can't really think of a reason not to give it. With heart attacks and myocardial infarctions, they say that as long as the saturations are above 94%, you can hold off oxygen, whereas they used to say give everybody oxygen that was having
that was my thought. Yeah.
But actually, if in doubt, give it, because it's better to give than to make somebody hypoxic, essentially. But in hospital, we would measure their saturation levels and we would titrate it against making sure they're above 94%. But no, I can't think of anything that you're going to really...
Because I remember listening to you when you come every year, and then most times you say grab the oxygen, and it makes sense. So it's good to know that, and it's reassuring. But back to our anaphylaxis fake scenario, I've given the upper outer. Zoe, my nurse, has got the oxygen, we put it on, we've filled up the reservoir bag.
Good.
Okay, you've shown us or described it to us exactly the 3-step process. So the grey thingy, the grey lid,
the grey cap, pull that down, turn the oxygen, the black controller, turn that to on, and then stick the oxygen, tubing onto it, turn it on.
And so a nice little dial, 15 is the max.
Correct.
Take it to there, and then put it on the patient.
And how long is it going to last, roughly?
Oh, I love this. Okay. I'm for some reason 40 minutes came to my head.
So don't not exact, but between sort of 15 to 20 minutes on 15 litres.
Okay.
So it runs out pretty quick.
Yeah, it does.
And one of the practices that I taught at did run out. They had an asthmatic, and this was more GP, so don't freak out. But yeah, there's a GP practice who ran out of oxygen, and they have to wheel their patient across the road to the care home to plug them into the wall oxygen. So it's a bit of a lesson that they then bought a massive cylinder, but you guys aren't using it as much as GP surgeries are. So that's
okay.
fine.
So you get 20 minutes on that. But our patient who's got oxygen, we've given one dose. How do you know? Are we looking for complete resolution, or if they're feeling a bit better, okay, we're good? And at what point should the ambulance be called?
Straight away, because you're given adrenaline, and actually you can get rebound anaphylaxis. So you could actually get another rebound in an hour.
So as a team, like one person get the oxygen, you get or another person get the adrenaline. Can reception please call 999 and say we suspect anaphylaxis, and then away you go?
Yeah, and I guess it very much is a clinician decision. If your patient is much better, then no. Do you need to give another one after 5 minutes? No. But if you're kind of umming and ahhing and they still look pretty grey and they still say that their breathing doesn't feel great.
I mean, it's pretty good stuff, right?
It's good stuff. And also, we're not going to cause much harm with adrenaline. So if we gave it and they didn't necessarily need it, they're going to feel like they've got a bit of a fluttery heart rate. But I thought dentists gave adrenaline anyway.
Yeah, with an anaesthetic. And it's quite often when we go in a vessel, they feel straight out. I've had it by myself before. I've had an injection in my lower incisor region, and my heart started racing straight away because it was injected into my vessel, and that's fine, Just
get them to run around the block a few times, and they'll burn it off. The good thing is it's got such a short half-life that if you gave it and you weren't quite sure, it's going to wear off very quickly. So I guess it does go back to a little bit of what you've got, the picture you've got in front of you, i.e. the patient, and do you think that they could benefit from another dose? Just to keep that breathing going, just to keep their blood pressure steady. If I was in doubt and I thought, actually, I'm not sure, I'd give another dose just to make sure.
Do I remember correctly that at some point in the guidelines it had hydrocortisone?
Yeah, so in the previous...
Or antihistamine as well?
Yep, there was chlorphenamine and hydrocortisone. Now, it's a bit of a grey area because they removed it from the initial algorithm in 2021. That doesn't mean that we don't give it. It just means that it's not part of your initial management. So when you're presented with a patient with anaphylaxis, say you were having one right now, what I don't want is someone saying, quick, go and get the Piriton, because the Piriton isn't going to vasoconstrict and bronchodilate. It's going to help with the source or the helping with the background allergy, but it's not going to save your life. So by removing it from the initial algorithm and putting it in sort of refractory anaphylaxis, it stops people running for the wrong drug, and it makes you prioritize the adrenaline a lot more.
So which, in that imaginary patient I described, should I also be supplementing it with an antihistamine?
Correct. Yeah.
At what point, which order? So
when you've got
ambience, oxygen, adrenaline.
Sort your patient out in terms of an airway point of view, in terms of a peri-arrest point of view, because obviously if we leave this patient, they could go into cardiac arrest. So try and manage that acute side of things. And once you feel like you've got time and you're not, trying to draw up drugs and keep the patient calm and raising the legs, then you can reach for the chlorphenamine and just make sure that their swallow's okay.
And chlorphenamine, is that tablet form? Okay.
Yeah, in hospitals we can give it.
So, antihistamine I've taken in the past, cetirizine, but we're not talking about that, right? Or...
Yeah, so chlorphenamine is Piriton. You've got cetrizine or loratadine.
So you can give any of those?
Yeah, you can give them. Okay. It's just, you just need to make sure they've got a safe swallow. Because what we don't want to be doing, if they're swollen, we don't want them to risk aspirating or anything. So just make sure that their swallow is safe.
Okay, perfect. Now, when I opened up this kit and it says severe allergy, should there not be some cetirizine or something?
Yeah, it would be helpful to have like a Piriton in there. But as long as we remember that the initial algorithm is anaphylaxis, fluids, or raise the legs. Obviously, we know that dentists don't give fluids, and oxygen. So what we worry about is putting something like Piriton in there, is that you'll forget about the rest of it and just give. So I guess it's up to the dentist.
It makes sense that we've done the important things. Okay, so I did actually find the pulse ox in there, but no sign of any cetirizine or
chlorphenamine.
Okay, chlorphenamine, there's none of that. But that's fine, because you explained why the adrenaline is the most important thing. But I think it's a good idea, perhaps, for it to be floating in the bag somewhere, just to give.
Or even in your practice, in like a cupboard or something, that if you don't have room in whatever bags you have, then you can always put it in the surgery somewhere. Because as I say, it's not an immediate life sort of saving medication, but it does help with the aftermath of a... Alternatively, you should be getting an ambulance fairly quickly. So it is something the hospital can always give.
Okay, great. So that wraps up vasovagal syncope and anaphylaxis. We also talked about oxygen, and we talked about different modes of delivery of the adrenaline. Was there anything else that we want to talk about in terms of the adrenaline itself, in terms of the different... We talked about Emerade having the correct dose, but being difficult to get hold of. Yeah. And the EpiPen and the Dextapen being a smaller dose, and that makes, ideally they should have 2, but time is of the essence.
Yeah. Emerade, I believe, have a 150 dose, a 300 dose, and a 500 dose. Whereas I believe that Jext and EpiPen just do a 300. But don't quote me, but I believe, that's what I've sort of been told.
Okay, great.
Well, there we have it, guys. Thank you so much for listening to our first ever series on the medical emergencies mandatory training. But I hope you found the style of listening and watching this, wherever you caught the episode, that it was a bit more relatable, more tangible, and more enjoyable than someone just telling you about all the drugs and speaking at you. Shout out to Rachel King Harris. She did a wonderful job, and very excited to share part 2 with you next week. If you got this far, you deserve your CE credit. Head over to protrusive.app to choose a plan that suits you. And if you're just ready to actually go for it and make this your best year ever, and check out all our master classes from VertiPreps, from Reservoir and Bridges, Sectioning School, and CPD for all the previous episodes, you need our ultimate plan. Head over to protrusive.co.uk/ultimate. I do want to thank Team Protrusive as well. For this one, it would be Jan, Chriselle, Nav, Erica for the publishing, and Marie, our CPD queen, who looks after you to make sure you get all your certificates. Thanks again, guys. I'll catch you same time, same place next week. Bye for now.